Hello dreamers. So let's start with a very small topic here, ocular injuries. So this topic we are going to this chapter, we are going to just learn point wise what are the features of blunt trauma, what are the features of a perforating injury. We'll talk about foreign bodies, intraocular foreign bodies, and we are also going to discuss about the chemical injuries. Okay. So we start with ocular injuries. Do we all understand the meaning of the terms? What is a closed globe injury? So when there is no rupture and when this the wall is giving away, that is called that is the rupture, right? So we'll just see the slides and understand what it all means. So suppose there is a blunt trauma, right? So we also, to remind you all, in injuries we have already talked about in the orbit chapter about the fracture roof of the orbit, which can lead to pulsating proptosis, if you remember, and we have already talked about blowout fractures, that is the fracture floor of the orbit, haven't we? So these things have been dealt with. Now we are talking about ocular injury, and first is your globe trauma, that is blunt trauma. So any closed globe injury, this is what is happening. Wherever there is an impact like this, it is going to put an impact at the equator this way, and the impact will also come inside like this. So this is the effects of the blunt trauma, very nicely depicted. What are we supposed to know at our level? What are the features of blunt trauma, right? So first of all, so how I would suggest you to learn is in my style, just make one diagram here. So you can make the diagram, keep making diagrams and depicting. Let me do it with the slides itself. So I'll do it here for you all. So what is the first thing outside to in, if you think of? So we will learn subconjunctival hemorrhage. Number one, so this is your subconjunctival hemorrhage. I would suggest all of you not to write simply, but make the diagram and write so that you will remember. Right? So this is point number one. Second, what next? On the cornea, due to the blunt trauma, we get corneal edema. So this is your corneal edema. Okay, so let's draw like this and show here corneal edema. What else you can see? What is the next feature? Tear in the Descemet's membrane. Okay, so Descemet's membrane tear. You can draw it on this diagram itself. Descemet's membrane tear. Next feature would be, you can make it on the same diagram. I am writing afresh, but you can put it on the same diagram on the anterior chamber. What you are getting? What is this? Blood in the anterior chamber. What do you call that? Hyphema. So this is your hyphema. These are all the features of, these can be the possibilities after blunt trauma. How does hyphema is very dangerous for us? Why it is? What is it causing? We all know, we have learnt in your glaucoma chapter, it can lead to glaucoma, and also it can lead to corneal staining. So this is again hyphema. And this one can, if you leave it, it can lead to corneal staining. And corneal staining can be permanent, right? Then you will have to replace the whole cornea. That is why this should be drained off very quickly. Okay? So this is your, this may lead to, you can write down corneal staining. That was about your anterior chamber finding, that is hyphema. What next? Behind the anterior chamber, iris. So you can draw it in the same diagram like this. Iris you can draw. This is what? Can you see this? We have learnt in the uveitis chapter also. Any disinsertion from the root, this is what is called iridodialysis. Iridodialysis. Disinsertion from root is iridodialysis. Right? Okay. Anything else it can lead to? Yes, it can cause sphincter tear, iris sphincter tear. Okay, on the diagram please. Again, this is showing you the sphincter tears. Same, iris sphincter tear due to blunt trauma. Okay? So we talked about, are you learning along with me? So we talked about what? We talked about subconjunctival hemorrhage. Next we talked the findings on the cornea like corneal edema, Descemet's membrane tear. Then behind the cornea, it was hyphema. It could be mild hyphema or it can be almost covering the whole anterior chamber, filling the whole anterior chamber. What are the two main disadvantages of hyphema? What did we learn? Glaucoma and corneal staining. What next we learned? Behind the anterior chamber, iris. What are the findings? One we learned is iridodialysis and second is sphincter tear. What else? Come to the angle. So what do you see in the angle here? Angle we are talking about. So if you look here, this is what is called angle recession due to tear in the ciliary body. So this slide is actually showing you through the gonioscopy. What we are seeing is, this is the angle recession glaucoma, right? So due to tear in ciliary body, what happens? This is angle recession glaucoma. Glaucoma is actually due to associated damage in the trabecular meshwork. But recession of the angle is happening due to the ciliary body, tear in the ciliary body. So angle recession glaucoma, right? Okay. Next, what do you see on the lens? We all have learnt it in our lens chapter also. This is the imprint of iris pigments on the lens. We call it Vossius ring. Vossius ring in the shape of the pupil. Okay? Yeah. So you can mark that. What else? What type of cataract? Again, this is an important exam question. Let me put the cues as well. This is Vossius ring is also a cue. And angle recession has not been asked in your exam as such, but yes, you have to know it, it's important. And of course, iridodialysis has been a cue. And what question they have asked you is, what is the shape of the pupil in iridodialysis? As you look here, it is D-shaped pupil. So it leads to D-shaped pupil. It's a feature of concussion injury, that is blunt trauma. Okay? What else? Yeah, so this one is done. Of course, this is also Q. They have asked you the effects of hyphema. So I have so many things are important here. Right. Okay. What is the next feature after rosette shape? Another question in rosette shape, it starts from, you will answer, it starts from posterior cortex. I have discussed this earlier as well. Okay? What next? We talk about, can you see here? The lens is subluxated downwards. So next thing due to blunt trauma can be subluxation of lens. Again, this is the trauma becomes the most common cause of subluxation. Exam question. Most common cause of subluxation of lens is blunt trauma. Got it? Yeah, so I was talking about that. What do you mean by globe rupture is when it gives way, right? And what is you seeing here? This is the iris prolapse. Okay? So this iris prolapse will be sign of globe rupture. It can happen after blunt traumas. Next feature, so you can learn one more, that is iris prolapse. Then we go more behind in the retina. These are choroidal ruptures. So you can see this choroidal rupture. All these lines are indicating choroidal rupture. Okay, one more important thing, commotio retinae. What was that? Exam question. This is also called Berlin's edema. So after blunt trauma, this cherry red spot is what is this edematous area, and the red spot, this is what is Berlin's edema. So there are other findings. You can see vitreous hemorrhage here. So it may be confusing, but yes, this is what is Berlin's edema. When the retina disinserts from its ora serrata, that is what is called retinal dialysis. Disinsertion from ora serrata. Disinsertion from ora serrata. This is again a giant retinal tear, right? So the retinal break can be a giant tear, a typical horseshoe shape. This is the giant retinal tear. So in retina, you can get a giant retinal tear. It's already written, sorry. You just have to understand the features. Yes, macular hole. The next feature that can happen due to blunt trauma is macular hole. Of course, there can be injury to the optic nerve, right? From the intraorbital or intracranial part, leading to optic neuropathy. So this is a traumatic neuropathy with some chorioretinal scarring. And any neuropathy, we all know, we have learnt in our neuro-ophtha. How does it present? The same 5 features: decreased visual acuity, visual field defect, afferent pupillary defect, decreased color, decreased brightness. Remember that? So everything will manifest. Okay, then these were the features of blunt trauma. Right? Very quickly, once more. What were the features of blunt trauma? Helping you with the diagram here. So you can just make one large diagram like this, and start labeling, right? So outside, of course, you will say subconjunctival hemorrhage. We talked about edema. We talked about Descemet's membrane tear. We talked about hyphema, right? Then we talked about iridodialysis. What is in the angle? Angle recession glaucoma, right? Then what is here at the pupillary area? Sphincter tear. So do you realize if you make the simple diagram in my style, if you try to learn in my style, this becomes even easier. Hai? What else? In the lens, because now these suspensory ligaments are affected, therefore you can get subluxation of lens. We may get rosette shaped cataract. We may get Vossius ring, isn't it? Then we can talk about, if this is the optic disc, this is the fovea, so what you get here is Berlin's edema. We may also get a neuropathy, traumatic neuropathy. And also choroidal ruptures. Lastly, choroidal ruptures. So if you just make one diagram, you know what are the features of blunt trauma. Life is simple. Let's talk about penetrating injuries. So penetrating injuries, we all understand that there has to be an entry wound. Perforating means there will be an exit wound also, right? First important thing is, this is most common form of injury is in small children because of this sharpened pencil. Very small children, they actually injure the other person's or the child's eye. Okay, so this becomes one of the most common cause of penetrating injury. Now this was your exam slide which was given in the exam, and they had asked you what will be your immediate reaction or immediate step if this patient comes to your OPD. Please don't answer, I'm going to take off the nail immediately. You will not do that. You're going to take this patient to the, of course you will do a detailed slit lamp examination, you're going to see for other things very quickly, but you will take him to the operation theatre. And in a very sterile condition, we are going to try this. Aqueous is going to leak out. You have to repair the cornea, right? Okay, this is another, this time it is not due to blunt trauma, but there is a tear in the cornea because of any penetrating injury, which can also lead to iris prolapse, as you can see here. What next you are looking at is when there is a laceration, how this has been, this is a repaired laceration of the cornea. So that could be one thing, corneal tear. And this is your scleral laceration, right? All of you tell me one very important thing when you talk about perforating injuries or penetrating trauma, what we have to keep in mind is about sympathetic ophthalmitis. Don't forget, after penetrating injury in one eye, there can be uveitis in the other eye due to the autoimmune reaction towards the uveal antigen. Okay, we are not going to forget this, right? It's important. So I would like to actually repair, that will always be my first step, is to repair the injury. And if this patient, if the injury is irreparable and I have to remove the eye, what did we discuss? We will never do evisceration, because when we are scooping, we can leave the iris or uveal tissue behind. So what we are supposed to do? We are going to go for enucleation to prevent any sympathetic ophthalmitis in the seeing and the remain one eye. Okay? So this is an important part and you have to remember that. Then this is what you are looking at is a tractional retinal detachment, which can also be one of the features of the trauma penetrating injuries, right? So in penetrating injuries, mainly it is the corneal tears, scleral laceration, iris prolapse. You have to keep in mind what is the most common mode. You have to talk about sympathetic ophthalmitis, right? And of course, any cause of scarring in the retina can lead to tractional retinal detachment. Right, so next we talk about our foreign bodies. Foreign bodies we will learn like this, that it could be superficial or intraocular foreign body, right? Let me show you a superficial foreign body. So this is one of the commonest we get in the OPD, right? And what we have to do with the 26 gauge needle, after putting an anesthetic drop, we just scrape it out if it is not very deep. And we pad and bandage with antibiotic ointment and it is going to be fine, okay? So this is one very important. And what is the most common mode of getting this? This is just an iron particle, mainly due to chisel and hammer. So this has also been an exam question. You should know this. This is again a superficial foreign body, as I just mentioned. Another could be in the palpebral conjunctiva. Again, you have to just scrape it out. Talking about the intraocular foreign body, any foreign body which goes intraocular will have three effects. Can we write together, please? What are the three effects? Write down mechanical effect. Mechanical effect, like for example, cataract can happen due to any capsular injury, or vitreous liquefaction can happen, retinal hemorrhage, retinal tear. As we just saw, it can even lead to different types of retinal detachments, right? So, mechanical effects because of that foreign body inside. Second, it can lead to infection. Therefore, any intraocular foreign body, we want to give prophylactic intravitreal antibiotic injections. And third, of course, it's toxic effects. So, these are the three effects: mechanical, infection, and toxic effect. If we talk about and divide the types of intraocular foreign body, we will write like this. It can be either inert or reactive. Just note down what are the inert foreign bodies. It can be glass, wood, plastic, rubber. You should know this. You should have an idea. These are inert foreign bodies in the eye: gold, silver, platinum. Reactive can be organic. Inorganic, what we have to learn? We have to learn about siderosis and calcosis. Right? Okay. So, these are the different types of intraocular foreign body possible. We know what are the three effects it can cause. So, we can see this is one intraocular foreign body here. This one is on the retina, in the posterior segment, in the vitreous. So, how do you work up if you get a case of an intraocular foreign body? So, when you get a case of, we have to do a detailed examination to know, and also not only detail anterior segment, posterior segment, we have to also do the gonioscopy, and of course, for posterior segment, we are doing fundoscopy. After this detailed examination that you have done, what is the investigation of choice? This was a recent question of your exam. So, it has to be CT scan, never MRI. Okay, why? Because it is not good if it is a metallic or metallic foreign body, right? So, generally magnetic ho sakta hai na, if the foreign body is magnetic, this is not recommended. So, don't do MRI, we will always go for, you will say, we will go for CT scan as the investigation of choice. And according to wherever we find it, how to manage it? Either I can take it, if it is magnetic, then I can use a magnetic removal for a metallic foreign body. So, metallic foreign bodies, I can use magnet, but otherwise we have to go with the forceps removal through pars plana vitrectomy. We all know how to enter through the pars plana. We are entering the vitreous cavity if it is on the posterior segment, and we will remove it. So, we go for pars plana vitrectomy. So, this is one exam question, will not forget, right? That was about how did you work it up, what investigations I did, and what are the options I have to manage it. This is clear now? Another very important topic we need to be discussing in detail is siderosis. Few questions here, we will discuss that. So, what is siderosis? It is iron, intraocular iron, isn't it? So, when you say intraocular iron, what is the most common cause? As we just learnt, is generally it says chisel and hammer injury. That is one question, number one. Please note it down. I am writing here only. Now, whenever there is a siderosis, what happens? What happens is, first is the lens deposits. There will be then iris pigmentation, and after iris pigmentation and lens deposits, as you can see, there are lens deposits out here. And then iris pigmentation, then there will be some retinal changes. Okay? And due to the degenerative changes that it is actually leading to electrolytic dissociation. And that is disturbing the whole thing. So, there is degenerative changes in the retina. So, when you do electroretinogram, I hope you have attended the retina chapter and you have seen, we have already talked about electroretinogram. So, when we are doing it, what we see, there is decreased amplitude of B wave. So, this is another important question. So, one question was the earliest sign of siderosis, it is lens pigment deposits. This is another question. So, I have already given you three questions for siderosis. One is, most common mode is chisel and hammer. Second is, first is your lens deposits. Third is that it is decreased B wave. And what was the question? It was not about decreased B wave this way. They had asked you, you have a patient with siderosis, how are you going to monitor his progress? What changes this intraocular iron is causing in the eye? And our answer was serial ERG. I am going to go for serial ERG. What am I checking? I am checking the B wave. Is it diminished or it is not? Okay. So serial ERG is required to monitor the serum. Now another thing is, which is the most dangerous intraocular foreign body? Then you shouldn't answer iron. The most dangerous is considered as, okay, that considered as copper. Okay, what you are looking here is the siderosis, the iris pigmentation in siderosis. We are looking at the iris pigmentation in siderosis. Okay, so what did I say? If they ask you the next, so next topic that we'll talk about is calcosis. So calcosis is nothing but copper in the eye, or actually it is copper alloy in eye. Okay, it can be due to any foreign body or due to Wilson's disease. We all know that. We are talking about foreign body here, isn't it? Pure copper in the eye. If it is pure copper, please keep noting down, it will lead to, pure copper leads to phthisis bulbi. That is why this is considered the most dangerous foreign body. So if they ask you, this is an exam question, most dangerous, we will not answer iron. Iron can be most common, but it is not most dangerous. Most dangerous will be copper. And what are the other changes it is causing? I think you are looking at, you all know this. This is the Kayser-Fleischer ring. It can be due to foreign body, iron, copper containing foreign body, or Wilson's disease, anything. So what it is? This is the deposition of copper, this golden brown ring at the limbus. Where is it deposited? They have asked you. We have discussed this. It is in the Descemet's membrane of the cornea. So please note down, this is your Kayser-Fleischer ring. Kayser-Fleischer, I have discussed in detail about Kayser-Fleischer ring already, right? So Kayser-Fleischer ring, this was in the chapter of disease of lens. So Kayser-Fleischer ring is namely copper deposition in the Descemet's membrane. We will say it is in the Descemet's membrane. What is the other finding of calcosis? Sunflower cataract. We have done this, sunflower cataract. Okay, so a quick recap here. Most dangerous foreign body, we are going to say copper. It can lead to phthisis bulbi. And this calcosis due to copper alloy is leading to what? It is causing Kayser-Fleischer ring as one thing. And second, it is leading to sunflower cataract. We have to remember these two features for calcosis. Don't forget, both are exam question. Right. So that was about siderosis and that was about calcosis. Done? So these are the inorganic intraocular foreign bodies in your eye. We next talk about is what are chemical injuries. Let's talk a quick review about the chemical injuries. First question they will ask you, which is more dangerous, acid or alkali? I hope you all know alkali is more dangerous. Can we put a Q here? Alkali is more dangerous. Why? Because acid causes coagulation of the protein, which will make a layer and it will not go intraocular. So penetration of acid through the cornea is not possible because of the coagulation of the protein. But alkali can penetrate the cornea and go intraocular. That is the reason alkali is more dangerous than acid. Samajh aa gaya? Should I tell it you again? Acid will coagulate the protein, and because of the coagulation of the protein, it will not go or penetrate intraocular. Okay. Now when you talk about alkali burn, most common but most dangerous is alkali burn and most common is also alkali burn. Okay. Most dangerous but most common is alkali burn. And it will cause most common alkali, it is mainly the ammonia. Right? Of course, it can be NaOH or lime injury, but mainly ammonia. Now, once we know this, of course, there is an exception written here about hydrofluoric acid, which is used in glass etching, which can rapidly penetrate the cornea. Though acids are supposed to not, this is an exception. But generally, they haven't asked you at your level, so if you want to ignore it, you can. So that was first question about chemical injury, alkali or acid burn. So when you talk about what happens due to alkali or acid burn, pathophysiology, please note down in an arrow form. First, there is necrosis of conjunctiva and corneal epithelium. So, necrosis jab ho rahi hai, when there is necrosis of conjunctiva and corneal epithelium, this disrupts the limbal vasculature. And when there is a limbal vasculature disruption, loss of limbal stem cells. When there is loss of limbal stem cells, therefore, you all remember, stem cells are like a boundary, they don't allow conjunctiva to encroach the cornea. But when the stem cells are gone because of the ischemia at the limbus, the stem cells are damaged. What happens? Conjunctivalization and vascularization of cornea. Conjunctiva tries to covers the cornea, and also there is vascularization of the cornea. This is what is happening as a pathophysiology in this condition, that is in chemical injuries. Right? And slowly, therefore, if there is deeper penetration, it will lead to stromal opacification. What happens as a late effect? Of course, scarring, and scarring will lead to symblepharon. We all know symblepharon is adhesion of the bulbar and palpebral conjunctiva, and it can even lead to psychiatrical entropion. We have talked about it in the late chapter. These are the late effects that a chemical injury can cause. Right. That was pathophysiology. So let us have a look what it is causing. What is this is the limbal ischemia it is causing. What will happen when there is a limbal ischemia? Necrosis and ischemia. It is damaging the stem cells. You know? Don't forget that. Again, a severe limbal ischemia out here. This one. Okay. Right. And what are you now looking at? This has led to adhesion of the bulbar and palpebral. This is what is called symblepharon. Okay, talking about the treatment for any chemical injury, what is very important to know here is, most important is copious irrigation, isn't it? So when the patient is coming to the OPD, the first important thing is you have to wash the copious irrigation, not only like this, but by double eversion of the lid. How will you double evert the lid? What was the name of the retractor? We would say Desmarais retractor. Remember, we discussed this? Okay. So once you have done that, of course, we'll start with antibiotics. We'll start with cycloplegics to control the inflammation and the uveitis. What else you can do? Of course, because inflammation is there, we want to control the inflammation, you can give steroids. But steroids should only be given for 7 days. Don't continue with steroids. What is the harm if you continue? It reduces the collagen, it impairs healing. Therefore, only for initial 7 days, for the acute control of the acute inflammation, you are giving steroids, but you will not continue as it will impair healing. And what is going to promote healing? We will talk about ascorbic acid. That promotes the collagen synthesis and improves wound healing. So you will start with ascorbic acid and citrate. This was your exam question. Ascorbic acid and citrate, you have to remember. What is the role of citrate? This was asked in the exam if you talk about management of chemical injuries. So citrate, it is not only a powerful inhibitor of neutrophils, but that means controlling inflammation, but it also chelates with extracellular calcium. Now this is important. When it will chelate with extracellular calcium, this citrate, calcium citrate, therefore what happens? Low calcium environment this inhibits the collagenase activity. Right? So the collagenase activity is all inhibited in the low calcium environment. So this was something very important and has been asked. You should know the role of citrate in management of chemical injuries. What are the roles? First was controls inflammation because the powerful inhibitor of neutrophils. And second, what did I say? Chalo batao. It is binding with calcium, because it is chelating with calcium. The low calcium level is leading to what? It is leading to inhibiting the collagenase activity. Okay. Also, we have role of tetracycline. This also is an inhibitor of collagenase, and acetylcysteine is also anti. So these tetracycline and acetylcysteine and tetracycline are all anti-collagenase. Just we will remember these are also anti-collagenase. But what is most important for you for the exam point of view? We are going to remember about ascorbic acid and citrate. Let's also discuss the surgical treatment. Surgical treatment, of course, when there is already scar formation or symblepharon, and what are the other things that you can do, sir? Of course, apart from division of the bands in the symblepharon, which is happening, now this is in the late, I started with this one, mentioning this first. You will cut the bands, but if you just cut it and don't do anything, it is again going to reform. Therefore, we have to go for conjunctival grafting, that is mucous membrane grafting or conjunctival grafting. You have to put something there so that it doesn't reoccur. What about the limbal stem cell damage that has happened? I can manage that with limbal cell transplantation or amniotic membrane grafting. Let's not forget this. Okay, so these two are, another is advancement of Tennant's capsule, but even if you at your level you remember these two, it is enough. So limbal cell transplantation or amniotic membrane